My husband on a ventilator with a tracheostomy go home with 24/7 ICU nursing. My name is Patrik Hutzel from Intensive Care at Home, where we provide tailor-made solutions for long-term ventilated adults and children with tracheostomies by improving their quality of life at home instead of intensive care and their families, whilst also reducing the cost of an ICU bed by around 50%. We're also looking after BiPAP, CPAP at home without tracheostomy. Tracheostomy without ventilation, also home TPN, home IV potassium, home IV magnesium, home IV antibiotic infusions. We're also providing a central line, PIG line, Hickman's line, as well as port management at home. We're managing cough assist machines at home, nasogastric tubes, PEG tubes, patch tubes, as well as we're providing ventilation weaning at home and palliative care services at home. So today I have some emails from Anne-Marie that's asking about her husband coming home, and I read out the emails verbatim as they've come in, and then I will go into how we can help Anne-Marie to get her husband home from ICU. Anne-Marie writes, "Hi Patrik, the ICU wants to discharge my husband with a tracheostomy and the ventilator very soon to a nursing home. I fear he's going to die there. Thanks for all your help so far and your emails. I hope that you can take him home with intensive care at home instead. So he will be getting home 24/7 ICU nursing, also respiratory physiotherapy, OT, speech therapy, and a home dietitian. I also spoke with a dietitian about the bolus feeding option. She doesn't have any experience doing the bolus with the nasogastric tube, only the PEG. So she will consult with a hospital dietitian who has some experience with a nasogastric tube at a different location. I see now why we're being pushed to do a PEG tube. His oxygen tolerance is being tested on 21%. What oxygen method do you think would be a good backup for home? An oxygen concentrator? Please advise, because that can prevent ICU readmissions. Thanks for your response." And then there's another email from Anne-Marie who says, "Hi Patrik, greetings. My husband's tube feed is from a pump. He gets 80 mils of formula per hour and 100 mils of water every 8 hours. I was informed by the dietitian that he was getting Banatrol in his tube feeds. But they intend to stop it since his stool is okay. Today, my husband worked with the speech pathologist and the physical therapist he set up at the side of the bed. I know they should be working with him more than once a week. I requested the debridement of his wounds, so the doctor will get back to me about this. I requested a transfer to another ICU or be discharged for home with intensive care at home, but I'm getting the runaround. He has good breathing, no fevers. His inner cannula is changed 2 times a day. Is this enough? He was given melatonin last night. I didn't like the side effects on him, and he has no problem sleeping. He was alert, responsive, and mobilized today, but it should be every day. Thanks for everything you do," from Anne-Marie. So thank you, Anne-Marie, for your question and for sharing so much detail about your husband's situation. Your fear that your husband could deteriorate and die if discharged to a nursing home with ventilation and a tracheostomy is absolutely valid and would become a reality if he would go to a nursing home, because nursing homes are not equipped to look after patients on a ventilator and tracheostomy. They do not have ICU trained staff 24/7 like we do here at intensive care at home. And that is why outcomes in nursing homes are often very poor for ventilated patients with tracheostomies. The good news is that with intensive care at home, we can safely bring your husband home with 24/7 ICU nursing, mechanical ventilation support, tracheostomy care, wound care, and all the necessary allied health support, such as physiotherapy, speech therapy, occupational therapy, and dietitian. We strictly follow the mechanical home ventilation guidelines that you can access on our website. These guidelines are evidence-based and are best practice for bringing ventilated and tracheostomy adult and children at home safely from ICU. Given that your husband is already tolerating 21% of oxygen, which is room air, that is excellent for backup at home. Yes, we can certainly set up an oxygen concentrator to prevent unnecessary ICU readmissions. We also provide suction machines, spare tracheostomy tubes, humidification, and heating systems, cough assist devices, monitors, dilators, tracheostomy dilators, ampu bags, dressing packs, the whole gamuts, the whole equipment that is needed to set up at home intensive care. With this tube feeding, we can continue with the pump or transition to bolus feeds if appropriate. Our ICU nurses and dietitians have experience with both nasogastric and PEG tube feeds and feeding. You are correct that hospitals often push for a PEG tube because of convenience when going home, but a nasogastric tube can also be managed safely at home if needed. However, as much as I often advocate against PEG tubes in general, once a patient needs to go home with intensive care at home and has no firm timelines to be weaned off the ventilator and the tracheostomy, which is the case for your husband, I would also advocate for a PEG tube because it is easier to manage and it will reduce the risk for hospital readmissions. As for his care in ICU, inner cannula changes twice daily are usually sufficient if there's no excessive secretion buildup. However, in the home care setting with our ICU nurses, we can assess and adjust tracheostomy care as needed on an ongoing basis. Sometimes the need to be changed 3, 4, 5 times a day, depending on what's happening with secretions. We also strongly advocate for a nebulizer use, the use of nebulizer machines with saline nebulizers. Get a script for that so that your husband can get normal saline nebulizers, because that will also prevent the tube from clogging, generally speaking, and mobilize secretions. The fact that your husband is sitting up, is responsive, alert, and working with therapists is very encouraging. He should indeed be mobilized more than once a week and at home. With intensive care at home, we can provide daily physiotherapy and mobilization support with our network. To summarize, Anne-Marie, your husband doesn't need to go to a nursing home full. It would be unsafe and inappropriate for his condition. He can go home with intensive care at home, where he will receive the ICU level support he needs in the comfort of your own home, keeping him out of ICU long term and keeping you and your family out of ICU long term. Also, with the bolus feeds, it really depends on what patients tolerate. It can be bolus feeds, it can be running through a pump. It really depends on how your husband tolerates the feeds and how he wants it. The other thing with melatonin is a natural product. I do not see any side effects from melatonin besides a better sleep, besides a better night's sleep. And I would argue that with your husband being in ICU for so long, he would have a disturbed day and night rhythm, which also means he might have a disturbed sleep pattern. So getting him a little bit of melatonin, help him to sleep during the night, and being awake during the daytime is not necessarily a bad thing. So that is what we, generally speaking, do for our clients too, so that they can sleep well at night and be awake during the day. Melatonin often helps. Now, with intensive care at home, we are currently sending our ICU and critical care nurses into the home 24 hours a day. We are providing the following: home care services for ventilated adults and children with tracheostomies with critical care nurses 24 hours a day. A genuine alternative to a long-term stay in intensive care or long-term acute care. Tracheostomy care for clients without ventilation. Home care services for patients on non-invasive ventilation such as home BiPAP, home CPAP. Home TPN, which is also known as IV nutrition. Home IV potassium and home IV magnesium infusions, IV fluids, and IV antibiotics. We are providing central line management, PICC line management, Hickman's line management, as well as port management at home. We're providing nasogastric tube and PEG tube management at home. The use of cough assist machines for our clients for airway clearance at home. Palliative care services at home, as well as ventilator weaning at home. We're also sending our critical care nurses into the home for emergency department bypass services. We have done so successfully as part of the Western Sydney Local Area Health District, their In Touch program, saving approximately $2,000 per patient that we keep at home instead of them going to an emergency department. That also means we're in a position to cut the cost of an intensive care bed by around 50%. An intensive care bed costs between $5,000 to $6,000 per bed day. Our service costs between $2,500 to $3,000 per bed day, and we're freeing up the most sought after bed in the hospital, which is the ICU bed. Most importantly, we're improving the quality of life for patients and their families, which is a win-win situation for all stakeholders. Of course, quality of life is much improved, surrounded by families and by a team of dedicated intensive care nurses in the home care setting instead of in an intensive care unit. With intensive care at home, we are currently operating all around Australia in all major capital cities, as well as in all regional and rural areas. We work with NDIS clients all around Australia, TAC and WorkSafe in Victoria, Department of Veteran Affairs all around Australia. Our clients and we as a service provider have also received funding through public hospitals, private health funds, as well as departments of health. We are having policies and procedures for intensive care at home nursing, and we've built all the intellectual property for intensive care at home since 2012. No other provider in Australia has created more intellectual property when it comes to intensive care at home nursing than we have. This puts us in a position to employ hundreds of years of critical care nursing experience combined in the community. No other service provider in 2025 employs a higher skill level in the community than we do, which enables us to look after the highest acuity adults and children in the community in Australia safely. So if you're at home already, and if you're watching this, or you're stuck in an ICU long-term, or if you're going to hospital and ED all the time, and you realize that you don't have the right level of support at home, or if you are stuck in an ICU, I'll give you a real-world example today how we can help you. One of our first clients when we first got started in 2012 was a client who was at home initially on a ventilator with a tracheostomy, with a support worker model 24/7. Of course, support workers are not equipped to look after a client at home on a ventilator with a tracheostomy. That is dangerous and it's simply negligent. Having support workers looking after a client at home on a ventilator with a tracheostomy is like flying the airplane with the cabin crew instead of the pilot, because anyone on a ventilator with a tracheostomy is at very high risk of medical emergencies 24/7, or even at high risk of dying if they don't have a team of dedicated critical care nurses looking after them 24/7 at home. This is actually evidence-based and is documented in our mechanical home ventilation guidelines that you can find on our website at intensivecarehome.com. Think about it. In an intensive care unit in a hospital, you wouldn't have support workers looking after your critically ill loved one or after any critically ill patient on a ventilator with a tracheostomy. So why would anyone in their right mind do that in a home care environment in the community? So this client at the time found out about us eventually, and the ICU that he was basically living in also knew about us and eventually reached out to us. And we were proving our concept with this client very fast. When we worked with this particular client, we sent him critical care nurses 24 hours a day, and he never ever went back into ICU ever again as long as we were working with this client. We can do the same for you if you're not safe at home and help you with keeping you at home predictably. Otherwise, we would not be in business. Again, the same is applicable for those stuck in an ICU, similar to this case study that I've just given you. Or if you're going back to ED all the time, please reach out to us. We can help you with taking you through the right steps, including how to get funding with different funding bodies. This is also why we are providing NDIS support coordination. We have a team of NDIS support coordinators, and they have a wealth of knowledge. I've done an interview with Amanda Richards, one of our NDIS support coordinators, and I'll put a link to an interview with Amanda in the written version of this blog. We're also providing TAC case management and WorkSafe case management in Victoria with Lucy McCodder. If you're an NDIS support coordinator or a case manager from another organization watching this and you're looking for nursing care for your participants, please reach out to us as well. If you need more evidence for nursing care, we are also writing NDIS nursing assessments with legal nurse, critical care consulting nurses. If you are a critical care nurse and you're looking for a career change and you want to join a very progressive, dynamic, and high-performing team of critical care nurses in the community, we're employing hundreds of years of critical care nursing experience combined. You can join this high-performing team if you are a critical care nurse. If you are looking for a career change as a critical care nurse, we're currently hiring for jobs for critical care nurses in Melbourne, Sydney, Brisbane, in Albury, Wodonga, in Bendigo, in Geelong, in Warragul, in Victoria. If you have worked in critical care nursing for a minimum of 2 years, pediatric ICU, ED, and you have already completed a postgraduate critical care nursing qualification, we will be delighted hearing from you. I do have a disclaimer though, because we are offering a tailor-made solution for our clients. which includes regular staff, our clients also do want the same staff coming over and over again because they are so vulnerable and so special. That's why we need regular staff. So if you're looking for agency work where you can come and go, this will not be the right fit for you. We are looking for consistency, and our clients are looking for consistency. So please only apply with us if you can give us regular and consistent availabilities for shifts, and you're really keen on building solid relationships with us and with our clients. If you're an intensive care specialist or an ED specialist, we also want to hear from you. We're currently expanding our medical team as well. We can also help you eliminate your bed blocks in your ICU and in your ED for your long-term patients, or for your regularly readmitting patients with our critical care nursing team at home. We're here to help you take the pressure off your ICU and ED beds, and in most cases, you won't even pay for it. Even if you do pay for it, it is so much more cost-effective than what you're paying for in ICU and ED, and you get the same level of care. And if you're a hospital executive watching this and you have bed blocks in your ICU, ED, and respiratory wards, or for home TPN, please reach out to us as well. We can help you eliminate your bed blocks very fast. If you're in the US and in the UK, and you're watching this and you need help, we want to hear from you as well. We can help you there privately with one-on-one consulting and with hiring nurses privately. Once again, our website is intensivecareathome.com. Call us on one of the numbers on the top of our website, or simply send us an email to info@intensivecareathome.com. And if you like my videos, subscribe to my YouTube channel for regular updates for families with intensive care at home and intensive care. Click the like button, click the notification bell, share this video with your friends and families, and comment below what you want to see next or what questions and insights you have from this video. Thank you so much for watching. This is Patrik Hutzel from intensivecareathome.com, and I will talk to you in a few days. Take care for now.